if you do not have insulin resistance, there is essentially no correlation between LDL and cardiovascular disease. On this week's podcast, super excited to release a conversation, what I believe is a very collaborative conversation between me and Dr. Mohammad Alo, a cardiologist who's been in the social media space for a little while. And what I like about this one is that we were able to go back and forth. Definitely, we both got passionate a few times. I tried my best not to interrupt him. I know I interrupted a few times. He interrupted me a few times, but we were really trying to give each other the space to talk. I was able to share quite a bit of research that I've done in the past. And so here is a direct answer to most of the mainstream ideas around lipids, around LDL, around cardiovascular disease, and incidentally around seed oils, because we know that seed oils will lower LDL, but raise oxidized LDL, Lp(a), and a number of other things that I talk about in this podcast. So we talked about all of it. This is a long podcast, but if you want to see me talk to someone whose views are different than mine, this podcast is for you. I try really hard to not just stay in the echo chamber and talk to people who agree with me. I really like these debates. I look forward to more of them. As I say in the podcast, unfortunately, it's been very hard to convince anyone who disagrees to come on the podcast. I've tried multiple people in the cardiology space, in the lipidology space, people who are outspoken about APOEB, and it just doesn't happen. So whatever, I'll keep trying, and I'm going to go to some cardiology podcasts and talk to cardiologists in person. But here is my cordial, friendly, but passionate and sharing different ideas conversation with Dr. Alo. I appreciate him for coming onto the podcast, my friends. All right, Dr. Alo, thanks for coming on the podcast. It's been challenging to get people on who had different views on lipids, so I appreciate you taking the time, and it's going to be a fun conversation.
Yeah, thanks for having me. I appreciate it.
So I think let's just jump right in. And I thought that the goal of this from the outset, as we've talked about via email and stuff, is not to have an adversarial conversation. I think we both agree that we're both doctors and we're both just trying to help people understand how to reduce cardiovascular risk of chronic illness in general. So I'm excited for this to be collaborative. I know people probably came to the podcast to see blows thrown, and I'm sure that at times we will disagree on things, but I really hope, I think it'll be fun to be more collaborative and just share different ideas about things and set the standard. Because in general, when I've seen adversarial debates, they're not extremely exciting or interesting to watch. But collaboration, I think, is how we all learn and grow in our thinking. So from the outset, I think let's just both maybe state our positions on this, and then we can kind of go from there. I'll let you lead off with maybe the first question would be, how do you think about cardiovascular risk, what causes atherosclerosis, and how to modify it? And we'll go from there.
All right. So, well, first of all, thanks for having me on. I'm a board certified cardiologist. I'm also a certified personal trainer. I don't know if people know that. I love coaching sports. In fact, I have some football to coach later today. But so for me personally, obviously I've been doing this a long time. I think if we back up a little bit and just talk a little bit about lipoproteins and what they are. I know your audience is very intelligent and, they're all into this, and I've watched and, even had debates with them online sometimes. But lipoproteins serve some very important purposes. A lot of people say, well, don't we need cholesterol? Why are you telling us to lower it? Doesn't your brain need cholesterol? Don't your testicles, hormones, adrenal glands, ovaries, doesn't all that need cholesterol? And yes, absolutely. Every single cell in your body needs cholesterol. And in fact, every single cell in your body makes its own cholesterol. So I think that's one thing that's very important to just say at the outset. A lot of people think I'm anti-cholesterol, or I think that cholesterol is this thing we need to completely eliminate. No, you really can't do that. Every single cell needs cholesterol, and in every cell membrane, you have free cholesterol. And cells would not function, they would not be fluid without free cholesterol. The problem comes in when you have too much cholesterol floating around in your bloodstream. Now, cholesterol is a fat, and it cannot float around in a bloodstream, so it needs to be packaged up into these things called lipoproteins. This right here is what the inside looks like. The yellow is cholesterol ester. The turquoise color is triglycerides. This blue thing kind of on the outside that kind of runs through it is a structural protein called an ApoB. I know you guys are familiar with it because we've talked about it a lot. But an ApoB kind of is what tags the low-density lipoprotein and VLDL, IDL, and lipoprotein a, the more atherogenic lipoproteins as the B structures. They have this B structure on it. The HDL, which let's say it's this other marker here, they have a different marker called an APOA1. They can have from 1 to 5 of them on their structure, and it's not very accurate to measure that, because what if one has 1 and one has 5? They're mostly in the form of 3s, but generally they can have up to 5 on each HDL. So this is very easy to measure. When you measure an ApoB, you measure like an exact particle count almost of your lipoprotein. My view is, and of course I consider this the accurate view, is that LDL cholesterol is causative of atherosclerosis. Brian Ferentz and his group from Europe wanted to prove, or at least say, what if we wanted to prove without question that LDL cholesterol is the cause of atherosclerosis? What criteria would need to be met in order for that to be accurate, or in order for that to be true? So they said most of the studies that are done on LDL cholesterol and show that it's not the cause, or it might be the cause, or it's not, it's questionable, are usually done on like a small subset of studies, and they don't look at the totality of evidence. So Brian Ferentz said, and his group said, let's just look at every single study that's ever been done on cholesterol. Don't take anything out. Don't exclude studies. Don't cherry pick studies. Don't do anything. Look at every single study ever been done. So they ended up with 20 million person years of follow-up. So for example, what does that mean? If you have 1 million people and you follow them around for 20 years, that's 20 million person years of follow-up. If you have 2 million people and you follow them around for 10 years, that's also 20 million person years of follow-up. So they wanted to look at every single study that has ever been done. And that's what they did. And they looked at Mendelian randomization studies. They looked at randomized controlled studies, cohort studies, genetic studies, pretty much anything you can imagine, epidemiological studies. Like they looked at pretty much every study that's ever been done, like I said, the totality of evidence. And they found that without question, no matter how you measure it, the higher the LDL cholesterol, the more likely you are to have atherosclerosis, heart attack, strokes, death, mortality from cardiovascular disease and non-cardiovascular disease. So they found in that case, after doing this, that it's very difficult to deny the science saying that that the LDL causes atherosclerosis. And we have like animal models. We've done human studies. We've looked at, how it happens and why it happens, and what happens inside even the arteries, at the microscopic level, looking at the progression of atherosclerosis inside the arteries. And it just turns out that the higher the LDL proteins or lipoproteins, the more of these you have floating around your bloodstream, the more of them get inside your arterial walls. And I'll just bring up this model we talked about. This is what normal artery looks like. This thin pink layer is the endothelium. As time goes on, you start getting atherosclerosis, but it's still inside the arterial wall. It's not in the lumen. You can still drive a truck through here without any problems. As time goes on, it eventually gets here to late stage. This is kind of the point where calcium starts building up. A lot of people say, well, my calcium score is fine. I have LDL 200, 300, what have you, but my calcium score looks great. It's 0. Well, do you want to wait till you have late stage atherosclerosis before you attack this problem? I give my patients the example. I say, well, it's kind of like smoking. If we do a lung scan and we finally find lung cancer, then we say, okay, now's a good time to stop smoking. Why couldn't we tell them, when they're teenagers, you should stop smoking, because we know decades later, 30, 40, 50, 60 years later, what have you, you'll have lung cancer. So it's similar kind of with lipoproteins and LDL cholesterol. We know that if you have ApoBs, there are people with genetic mutations that have an ApoB of like 10 to 15. These are people with PCSK9 loss of function mutations, which is how we invented the PCSK9 medications like Repatha, Praluent, and now inclisiran. People with knocked out PCSK9s, or the PCSK9 gene doesn't function, they have an LDL cholesterol of like 10, 15, maybe 20 at the most, and they live the longest, and they live the longest atherosclerosis free. Sure, as they get older, they'll probably get something else. Obviously, everyone has to die. But we know that they at least won't have atherosclerosis. So that's kind of where the consensus of the data is, the studies. Almost every study that has been done that lowers LDL cholesterol has definitely proven to have better outcomes than not. So that's kind of my stance. I don't know. I'd be interested in hearing your view on it. I've watched a lot of your videos and your podcast. I don't think we differ that much in our views, but fire away.
So my perspective is a little different than yours. And it is that cardiovascular disease is a really important problem for humans, and it's critical that we are careful in our consideration of this disease and that we are detail oriented in our consideration of the risk factors so that we can help people understand what the true risk factors are. For instance, if we are looking at LDL as the wrong risk factor, or there are other more important risk factors, I think it's important to point those things out to people. And so when I hear arguments like the totality of the evidence, I'm reminded of the way that vegans think about plant-based studies and meat studies. And if you look at the totality of evidence for vegetables versus meat, for humans, you can draw conclusions that I think are false, which is that meat is bad for humans, that meat is associated with decreased longevity, that meat is associated with increased incidence of cardiovascular disease, when, if you look at the details, you arrive at different conclusions. So I think that arguments based on totality of the evidence are dangerous, and we need to dig into the details. The devil is in the details, as they say. And when I look at the details of LDL in connection with cardiovascular disease, what I find is that there are many instances that are important, not just a few, but there are many instances that are important to consider where LDL cholesterol does not associate with cardiovascular disease. And so you have any study in which LDL cholesterol is stratified by a metric that correlates with insulin sensitivity or insulin resistance, you see totally different amounts of correlation between LDL and cardiovascular disease when people are very insulin resistant versus minimally insulin resistant. There are genetic outliers like glycogen storage disease 1A or von Gerke's disease, where people have hyperlipidemia, but no increased atherosclerosis. There are many, many elderly studies in which people who are 80, 85 plus, who have elevated LDL cholesterol, tend to live the longest. There are cardiovascular studies, specifically autopsy studies done by Patterson and others in the 1960s, in which the serum cholesterol was taken prior to patients' deaths, and then that amount of cholesterol in the blood was then correlated with the directly observed in the coronary arteries, cerebral arteries, aorta, and femoral arteries, amounts of atheroma. If you look at the amount of ApoB in a plaque, that doesn't correlate with the amount of ApoB in the serum, suggesting that there's discordance there between ApoB in the serum and ApoB in the plaque. Similarly, and this is the work of Sam Semikis, if you correct LDL for Lp(a) levels, then LDL corrected for Lp(a) is no longer predictive of cardiovascular disease. It's only when the Lp(a) component of LDL is not accounted for that LDL is connected with cardiovascular disease. And so we run into all of these problems. And I think this is what I was saying to you earlier about this what is water. There's this amazing commencement speech that David Foster Wallace gave, and the title of the speech is What is Water? And the summary of that speech is that there are these two fish and they're swimming around and they pass an older fish. And the older fish says, "How's the water today?" And they don't know how to respond and they kind of swim away and they ask each other in private, "What is water?" And so when I see the mainstream analyses, like you're talking about, of these Mendelian randomizations, these interventional trials with statins, these observational studies with LDL lowering therapy, or these other observational studies, and I see that and I think, okay, is it possible that there's another explanation for that we're missing in the name of quote unquote totality of the evidence? And I think that there is. And I think there's another possibility here that we need to consider if we really want to understand what the true driver of atherosclerosis is and whether we can truly say that LDL is a cause of atherosclerosis. So this goes back to the first thing that I said, which is that anytime you have a metric which stratifies LDL and cardiovascular risk by insulin sensitivity, you see something completely different at the highest versus lowest levels of insulin sensitivity. And you and I may disagree on this, and I can show you the literature that I would use to support the fact that 90+% of Americans are not optimally metabolically healthy. So if the majority of people that you're looking at in these Mendelian randomizations, statin interventional trials, et cetera, are metabolically unwell, it's quite possible that they all have significantly elevated levels of oxidized LDL or elevated fractions of oxidized LDL as a percentage of their LDL, elevated levels of Lp(a), and we can get confused into thinking that LDL is causal when in fact it's just getting wrapped up into the equation. And I think that there's an illustrative example that you and I have gone back and forth on Twitter about that we'll talk about that I think will help people understand this at a very high level before we get into the details. But that's my general perspective, that I think that though there is this log linear correlation between Mendelian randomizations and LDL lowering and cardiovascular risk in the statin trials and the other observational trials, I think it's also possible that we're making a philosophical error of judgment because the majority of patients we're looking at are metabolically unwell. And we know that when people are metabolically unwell, there's a strong correlation between LDL and cardiovascular disease, likely because of increased levels of oxidized LDL and Lp(a). We can't really say that means LDL causes atheroma. But the real targets are probably, in my opinion, insulin resistance first and foremost, and then the subsequent increase in the susceptibility of LDL for oxidation and the connected increased cardiovascular risk with Lp(a). And those are very different targets than LDL-C per se. Does that make sense?
Yeah, that makes sense. Let me offer this explanation.
This stuff really works. Check out this review on histamine and immune from Heart and Soil Supplements. My husband was suffering from seasonal allergies to the extreme. Every day his eyes would be swollen shut upon awakening. He was constantly sneezing and just miserable. He made an appointment with an allergist, but I asked him to wait and try these out for 2 weeks first. He didn't go to the allergist because he's been totally symptom-free, taking histamine and immune from Heart and Soil Supplements for 5 days for the full effect to go into place, and he has stuck with it. These really work. Histamine and immune is a pretty incredible supplement from Heart and Soil. It contains thymus, lung, liver, spleen, and kidney. And the reviews on this one are amazing for histamine reactions, for allergic reactions, for seasonal allergies. Check out histamine and immune from Heart and Soil at heartandsoil.co. And all of our supplements, which are grass-fed, grass-finished, regeneratively raised, and, as you know, always in glass because plastic is bullshit. You don't need that in your life, in a landfill, or in the ocean. So proud of what we do there. Heartandsoil.co, histamine and immune, and all of our supplements are there.
So the oxidized LDL thing, cardiologists and the world of cardiology stopped looking at that maybe in 2005. Even some of the guests you've had on your podcast have said that that's not really an issue. The liver clears oxidized LDL pretty quickly. So does your immune system. So that's not the problem. You can't really argue that.
We'll talk about that. I disagree with you, but we'll talk about that.
I mean, we could talk about it, but let me give you sort of my explanations as for the things that you were saying. There are some people who have things called insulomas, where they have these tumors that secrete a ton of insulin, and they don't have increased atherosclerosis. Another thing I'd offer is the percentage of people that are actually insulin resistant in the United States, according to CDC guideline publications and stats, 9% of all people have type 2 diabetes in the United States and pretty much worldwide. 11% have diabetes because type 1 is also included. It's another 1 to 2% of the population. The amount of people, if you look at the CDC, that count people as insulin resistant, like pre-diabetic but not yet diabetic, is probably, depending on the study you look at and how you want to measure it, anywhere from like 15% of the population up to like maybe 38%, let's just say 40. But they have done studies. For example, there were studies that have been done on people who are completely like metabolically healthy, like these young kids. There's multiple different kinds of familial hypercholesterolemia. There's monogenic homozygous, right? These are the worst of the worst. This kid by age 5 has already had a heart attack or stroke, subsequent ones later, and is dead by age 20, without question. Monogenic homozygous. The monogenic heterozygous is a little bit, not as bad. They might get to 25, 30. The polygenic homozygous by age 30, 35 has had their first event. And then you have the, polygenic heterozygous, which could make it up to like 50, 55, depending on their sex, with atherosclerosis. So those are people that are generally healthy. Their LDL is, big and fluffy. They don't have insulin resistance. They're young kids, what have you. There are some trials that have been done to answer this exact question that you're asking. What if we took a bunch of young, healthy people, no atherosclerosis, no insulin resistance, CAC score of 0, your calcium score of 0. And what if we looked at them and just looking at what do they have? What if we looked at, subclinical atherosclerosis? It was called the PISA trial, the prevention of early subclinical atherosclerosis. These people had an average age of 45, maybe 46. Only 15% of them were overweight or obese. So very lean. And they looked at very high quality imaging. This is like 3D, MRI, intravenous IVs, like all kinds of stuff that's not available to us as clinicians. There's, super high tech imaging. They found that 45% of people with an LDL of 110, which was normal at the time, we don't consider that normal anymore, but 110, 45% of people had atherosclerosis. And then if you looked at people with LDL of 130, it went up to 58%. And if you looked at LDL of 150, it was 64%, which like almost 70% had subclinical atherosclerosis. And most of those people that had it in one bed had it in more than one arterial bed. 63% had atherosclerosis in more than one arterial bed. So that one kind of goes against that. There's another study very similar called the Cardia trial, where they looked at about 5,000 young men starting at age 18 to 36. And they looked at people who had the lowest LDLs versus the highest LDLs. The people who had the lowest LDL had the time to first visit for an atherosclerotic event of like 15 years more than normal. Whereas the higher the LDL went, the sooner and sooner they actually had to see and had an incident event or like that first event. In terms of, autopsy reports, they've done autopsies on fetuses, miscarriages, and abortions where mom had cholesterol of like 200-300. They had fatty streaks in their aorta. Vietnam, war veterans, autopsy veterans from World War II, same thing. The higher their cholesterol, the more fatty streaks and the more atherosclerosis they had. So I think that kind of argues against it. The Jupiter trial, which was a primary prevention trial where they put people on Crestor and whatnot, that's besides the point. But the amount of people that were overweight in that trial was only 15%. So again, I feel like these studies have been done. A friend of mine on Twitter asked me one time, can you please steel man the carnivore diet? If you had to argue for the carnivore diet, steel manning, I'm sure you know this, but for your audience, is when you take the position of the opposition and say, give me your best shot. You're the cardiologist, you're America's cardiologist, whatever you want to call it. You know everything about this. Argue for carnivore for me. Tell me why I should eat red meat, right? So it was kind of a fun exercise. So I said, listen, here's what I would do if I was a carnivore and I wanted to promote this diet and this lifestyle. Here's what I would say. I'd say, look, just stop denying the evidence about ApoB and LDL-C and just leave that stuff alone. Say, yes, absolutely, high LDL, it is a problem, no big deal. Not everyone's LDL goes up with a red meat diet. Only like 30% of people. And then argue for like how you feel on the diet. Not everyone feels good on the diet. I'm sure you've noticed, some people have sent you emails or whatnot. But if you feel great on the diet, and I don't care what diet it is, you could do keto, you could do intermittent fasting, whatever diet you can adhere to. If you lose weight, or, we're very happy for you. All of your cardiovascular markers will improve with the weight loss alone. But let's say you do this carnivore diet, you lose 40, 50 pounds. You are going to feel better. It's an elimination diet. It gets rid of a lot of things that, people might have, various kinds of, who knows, inflammation, what have you. But the weight loss alone improves your cardiovascular markers for the vast majority of people, even though it's higher saturated fat, red meat, what have you. So argue that way, say that. Stop talking about oxidized LDL and big LDL and little LDL. That makes no difference in cardiology. Whether you're LDL, all LDLs between 20.
Okay, I'll show you things that completely disagree with you there, but I'll show you evidence that says, yeah, absolutely.
No, I know. There is absolutely evidence. There's totally evidence for almost anything you want. I mean, you can look it up. That's easy to do.
How can you say oxidized LDL is not a risk factor for cardiovascular disease? Because
it oxidizes inside the arterial wall. If that's what you mean, yes, absolutely.
Yeah,
but not circulating.
No.
Circulating oxidized LDLs.
No, but I'm talking about the propensity of LDL to oxidize in the arterial wall. I want to bookmark that.
That's a different story.
We'll come back to that because there's solid evidence that increased linoleic acid in the human diet will increase the propensity of LDL to oxidize.
Yeah, I mean, we can get into seed oils. Yeah, we'll get into the linoleic acid and seed oils. That's not a problem. But inside the arterial wall is a different story. I thought you meant like circulating oxidized LDL.
No, I didn't say that. I said oxidized LDL in the arterial wall. And LDL
that made big pharma and big laboratory a lot of money, but it was a useless test. But so I would tell people, listen, just stop arguing with the stuff that just makes no sense. Just say, listen, I feel great on this diet. I lost a bunch of weight. My numbers actually got better. My inflammatory markers got better. My LDL went down. ApoB went down, what have you. That's all fine. There are going to be some people, if they eat keto, like a high saturated fat diet, their numbers are going to go up. And I know you're not keto, But their numbers will go up. And those people just say, listen, if you like this diet and you want to eat this way, just let us treat down your LDL. It's really not a big deal. There are medications now that will crush your LDL if you want it to, like, the Repatha on top of a statin plus Zetia plus whatever. We can get your LDL down to, like, the Fourier trial. If you looked at it, we got people's LDLs down to 0.2 millimoles, which translates into like 7.5 milligrams per deciliter. And they followed them for a long time. Nothing bad happened. But they had reduced cardiovascular outcomes.
They still had
mortality,
cardiovascular disease incidence, though. I mean, even at the low
it was no. I mean, it was almost nothing. I mean, we know from the Jupiter trial, below 57, LDL below 57, you almost have no atherosclerosis. So way below that, you have almost nothing. I mean, that's not even possible. But now back to the insulin resistance. Absolutely, if you take ApoB, people with an elevated ApoB, and throw on smoking and insulin resistance and hypertension and social determinants of health, lack of exercise, obesity, especially abdominal obesity. You tag on all that stuff, absolutely, their risk goes way, way up. That's not even a question. I mean, that's been established for years. I don't think anyone's arguing that. But the more of these things you stack on to a high ApoB, you do get all of these things, obviously.
Yeah. Okay. So lots of things. I have oxidized LDL, insulinoma, insulin resistance, FH, PISA study, Cardia study, autopsies, and Jupiter that I want to respond to that you said.
Fire away.
But before we get into any of that, I think that I want to just do, I have thoughts on all of those things. I want to do two things. I want to show data corroborating my claim that 90+% of the United States is not optimally metabolically healthy. And then I want to ask you,
what is your definition of metabolically healthy?
Well, I'm going to show you the data.
Sure.
Yeah. They don't meet criteria for optimal metabolic health. And then I want to ask you about atherosclerosis in veins versus arteries, because that is it's not super technical. I think that all of these discussions about insulinomas and FH and PISA, cardio autopsies, Jupiter, they're going to get a little technical. So I want to talk about veins and arteries before we get into the technical stuff, but we'll get there. So there are two studies done recently in the last few years. Here's a screen share. Trends and disparities in cardiometabolic health among U.S. adults, 1999 to 2018. So this is published, I think, in the last few years. This is probably a 2021 study.
It says 2022 right at the top.
Yeah, 2022. So you can see here in the conclusions that the percentage of U.S. adults with optimal cardiometabolic health is.
But how did they define that? What is the definition?
It's right up here. Adiposity, blood glucose, blood lipids, blood pressure, and clinical CVD.
Oh, yeah. I mean, if you include all those things, absolutely, that's like the entire country. But Paul, that's the entire country. That's literally the whole world's population.
That's what I'm talking about. And let me show this other study. That's exactly my point. But
no one is arguing that.
Well, yes, you were sort of arguing that. But my point is that when the whole country, right, is metabolically unwell, could that confuse us into thinking that LDL is associated or causes cardiovascular disease? This is the point that I'm making, that we are disagreeing foundationally about the overall metabolic health of our citizens. You were saying that...
No. I'm not disagreeing.
Please don't interrupt me. I'll let you talk. You were saying that 10% of Americans, give or take, have diabetes, and the highest estimates were that 30% are insulin resistant. Now, I would contend, no, 90% of US Americans are metabolically unhealthy. Here's another study. This is from 2019, essentially showing the same thing. 12.2% are metabolically healthy. And they defined it the same way. It's these metabolic syndrome criteria. So we've got waist circumference, glucose, hemoglobin A1C, blood pressure, triglycerides, HDL cholesterol. So yeah, I think that if you look at reasonable metrics, these are not like crazy metrics. They don't even have fasting insulin in here, which I think would be the sort of be all end all cardiovascular disease metric. But if you look at reasonable metrics of metabolic health, no one is metabolically healthy except for a very small percentage. So considering that, isn't it possible that if we are all swimming in dirty water, that you are going to see a consistent correlation between LDL and cardiovascular disease, leading people to believe, potentially incorrectly, that LDL causes cardiovascular disease? And I can show, and I will show later in this podcast, there are multiple studies in which LDL risk with cardiovascular disease is stratified by insulin sensitivity. And in these small cohorts, but hopefully you and I are part of this small cohort of people who are insulin sensitive, so it matters to us. In this small cohort of people who are insulin sensitive, there's essentially no relationship between LDL cholesterol and cardiovascular disease. So how can LDL cause cardiovascular disease if that's the case? This is the point that I'm making broadly, is that I think that we've got it wrong. And I think that we're treating the wrong target. And so when you say, if you want to do a carnivore diet or an animal-based diet and your LDL goes up, we can smash your LDL down. I don't think we should be focusing on LDL. I think we should be focusing on Lp(a), which is a much better risk factor, oxidized LDL in the arterial wall, and most importantly, insulin sensitivity. So I think that when we are honest about how much of the United States is insulin sensitive, we come to a very different conclusion about the water that we're all swimming in. And I fear that that is leading us to a very different interpretation of the data. So this is where context matters. So I think that with those two studies, we can reasonably agree that, like you said, the majority of the country is unwell. I mean, I've heard you criticize me saying this in the past on other podcasts, but I just showed you data that 90+% of the United States is metabolically unhealthy.
I'm not disagreeing with that at all, but we know, and I mean, you worked in cardiology, you've seen it. The vast majority of people in the United States absolutely have hypertension, have cholesterol, have obesity, have everything. Like 83% of the country, if not more now, this was from 2019, CDC, 83% of the country is overweight, 42-ish% of adults are obese,
It's
almost 20% of
overweight and obese.
Right. Almost, I said 80% overweight and 40% obese. Children, age 5 to 19 years old, 18 point something percent overweight. The whole country is overweight, has hypertension. That's not, I think, what you meant when you were first talking about metabolically unhealthy by just insulin resistance. It's not just that. I mean, yeah, sure, 9-10% of the people have diabetes or what have you. You want to throw in hypertension and all that other stuff. Absolutely, I agree. But we've shown even in people with all of those things, if you treat down their LDL cholesterol low enough, whether they're hypertensive, whether they're obese, whether they're smokers, whether they're whatnot, the chance of them having atherosclerotic events is completely reduced, like you said, in a log linear relationship. So we don't have, I mean, that doesn't explain that. If you took these kids with FH, or if you take people with a PCSK9 loss of function mutation, run around the LDL of 15 their entire lives, even if they're obese and smokers and hypertensive, what have you, their chance of having anything atherosclerotic is incredibly low. They might get cancer, they might get who knows what, but still they're not going to have atherosclerosis. That would be my argument there.
So what you said, I just want to highlight what you just said. You said that if we treat people with obesity and insulin resistance or diabetes with statins, we can reduce their cardiovascular disease risk. I agree with that. I'm not disagreeing with that. What I'm saying is that in people who do not possess indices or markers of insulin resistance, there is a large amount of data suggesting that LDL does not correlate with cardiovascular disease. This is the nuance. This is the devil in the details that I want to bring out.
Explain it again.
What I'm saying is that in people, if you treat people who have obesity, who have high blood pressure, who are smokers, any of these metabolic syndrome criteria with statins, and you reduce their cardiovascular disease risk, I agree with that. They're insulin resistant. But my point is that the people who do not have those issues, there is essentially a vastly attenuated correlation between LDL and cardiovascular disease, or no correlation between LDL and cardiovascular disease. So saying that we can treat people who have insulin resistance and reduce their cardiovascular disease risk by lowering their LDL doesn't prove the point. What I'm saying is that just that consistent correlation is where I think we're getting LDL wrong, right? That LDL in people who are insulin resistant, there is a consistent correlation with cardiovascular disease, but not in people who are not. And so this, I think, is a key part of this discussion. And it points out to the broad cardiology community that by not checking metrics of insulin resistance and by not broadening our perspective of what insulin resistance and metabolic health are, we're missing people because we're just trying to treat their LDL, when what we should be going after is their insulin resistance. And I want to talk about insulin resistance later in this podcast. But that idea that in people who are metabolically unwell, and according to those two studies, it's either 6.8% or 12.2% of the American public, there is essentially no correlation between LDL and cardiovascular disease. That is a key detail that gets lost in the totality of the evidence arguments. Does that make
I mean,
sense?
I don't think that what you pointed out shows that there's no correlation between LDL or
Oh, I'll show you.
ApoB and the atherosclerosis in those people.
Oh, I'll show you. Hold on. I'll show you a
all
graph.
all it showed was that lots of people have disease of all kinds.
No. What I'm saying is I'm saying that as a categorical thing, and I'm going to show you evidence that there's no correlation. So there's multiple studies which show this. So here is the Framingham data. So if you've seen this, you've probably not seen this graphic of Framingham, but if you look at the overall Framingham data of cardiovascular disease, increasing incidence of cardiovascular disease on the y-axis, LDL-C on the x-axis, and you don't stratify by any metric that is associated with insulin resistance, you get a straight line, just kind of like the same visual representation of a log linear.
Well, I mean, HDL is not
wait. Let me
important.
HDL is important. HDL is important.
No, HDL is not cardioprotective. It has.
Wait. Please let me finish here. Please let me finish here.
Go ahead.
So what I'm saying is that in this study, HDL, I think, is a reasonable proxy for insulin sensitivity. That's my point. I'm not making the point that HDL is protective. I'm not making the point that we understand everything about HDL. What I'm saying is that if you stratify the Framingham data, which is a very large study, by a metric like HDL, they didn't check fasting insulin in Framingham, unfortunately. But if you stratify the Framingham data by HDL, what you see is a vastly different correlation between LDL and incident cardiovascular disease. Look at this top one. If you have a low HDL, the majority of these people are going to have metabolic syndrome. This is normal human physiology.
Right.
This is dyslipidemia, right? This is metabolic dyslipidemia. That's what I'm saying. This is a metric that is a proxy of insulin sensitivity. 45, a little better, 65, 85. People with an HDL of 85, some of them are going to be insulin resistant, but very few of them are actually going to be that way, right? So what you see is that LDL, and I'm going to show you other studies to corroborate this point, because every time we look at this, we see this. If you stratify the relationship between LDL and cardiovascular disease by any metric that reflects insulin sensitivity, you see this exact pattern, that LDL is no longer correlated with cardiovascular disease. Let me show you one more just to drive it home.
Can we just go back to that for a second?
Yeah.
So the people, what you're showing is people have LDL and then you're stratifying it by HDL. Yeah, absolutely. People have a low HDL, have high triglycerides. That's why their HDL looks suppressed, and it even is, because they're full of triglycerides. You're picking the worst of the worst. You're picking people who have every human metabolic, insulin resistance.
That's my point.
Smokers, what have you. Absolutely. Like, why is that a question?
But my point is that if you look in people, and I'll show you another study, when we do any of these stratifications of LDL versus cardiovascular disease by a metric that associates with insulin sensitivity, we see vastly different correlations between
that's not
LDL.
Something new. We've known that.
But this is my argument. I think we're not understanding each other here. So
no one is disagreeing that insulin resistance is horrible for you.
My point is the opposite of that, which is also this detail that if you do not have insulin resistance, there is essentially no correlation between LDL and cardiovascular disease.
Okay, that's a different argument.
That's what I've been saying the whole time. That's what I've been saying the whole time.
But all of the studies that I quoted, and I'm sure you've read some of them, all of them show that the very few, the percentage of people that were unfit or unhealthy or metabolically unhealthy were low amounts in those studies, and they showed that ApoB and LDL cholesterol, even at quote unquote normal levels, still had atherosclerosis developing. So even people who were not obese, super lean, no insulin resistance, none of that, still had atherosclerosis if their LDL cholesterols were even quote unquote normal. That's why we've lowered the normals to even lower now, because we know more. So that would be the argument. I mean, you've got kids that are having atherosclerotic events, before their teenage years with super high LDLs.
That's FH. We can talk about FH. That's different.
I mean, it's not different. It's the same thing. These are people with no metabolic disease.
FH is not the same thing. I'll tell you. We'll talk about FH in a moment. But let me go back to your point here, which is that in those studies that you're mentioning, they're not assaying. I think that we're blind to insulin resistance. You're saying that in these studies, a small percentage of people have insulin resistance. But then you also told me that only 15 to 30% of the US population has insulin resistance. And I'm showing you data that 90% of the US population has suboptimal metabolic health, has some degree of insulin resistance.
I think you're confusing insulin resistance with like hypertension.
No, I'm not,
obesity,
because hypertension we know is essentially synonymous with insulin resistance. Those
it's
are
not, though,
connected.
Paul. I have plenty of patients, I'm sure you do too, that have hypertension and obesity and have like an A1C of 4.4.
That doesn't mean wait, A1C is not a metric of insulin sensitivity. What is their fasting insulin?
I don't know. I haven't checked.
Exactly.
But still,
you haven't checked. So you don't know
if
how
somebody's
A1C,
if someone's A1C is 4.4, it's highly unlikely that they have a fasting insulin of 30 or 80 or 15 or above 4, whatever it is.
I disagree with you.
Very unlikely.
I disagree with you. So this is, I think, is where Western medicine is missing the boat. That we are not, and you said this, we are not checking fasting insulin on our patients. So we don't understand that there is
we have fasting glucose,
but it's not as good as fasting insulin, right? Because
it's pretty close.
It's not even close at all.
But you can't use fasting insulin without a fasting glucose. You have to relate the two.
If somebody's relate the two, but
somebody's glucose is 80, fasting glucose 80, and their fasting insulin is like 30, they have a problem. That's a different story.
And that happens. We see people who have a fasting glucose of 80 and a fasting insulin of even 10 or 11. I would say that any fasting insulin above 5 micro IU per ml is too high. If you look at a Gaussian distribution of fasting insulin in the US population, the average is 9. The average is 9. And so what we know is that if you look at these metrics, I would say that this is probably the most important point for us to try and communicate to each other. I know we're getting a little bit excited about this and kind of talking over each other.
No, I'm not getting excited at all. I mean, that's fine. I'm telling you that, like you said, 90% of the people, or whatever percentage that was, have hypertension, have obesity. All of that is corroborated. You don't even need a study for that. I mean, just look at the CDC statistics. Super easy. You don't even need to study it. It's absolutely, the vast majority of people have one of those things or all of those things or a combination. And that's how most of those people end up being cardiac patients, in addition to, at least from my perspective, that their ApoB was high. And for the longest time, we had such a high target for ApoB and we didn't lower it. But of course, I think you have a different view, but without that ApoB being up there, they wouldn't have heart attacks and strokes. They might have smoking, lung cancer, obesity, hypertension, sleep apnea.
That's wrong. And I'll show you a study that contradicts the point you just made. So here's what we're saying. So there is something called Dunnington familial partial lipodystrophy. And I'll show you this study. And these people have a monogenic mutation at the LMNA gene. It's a single gene polymorphism. And they have insulin resistance, and they do not have elevated ApoB, traditionally speaking. And they have massive, aggressive cardiovascular disease. So to say that people who have insulin resistance without elevated ApoB are not going to get cardiovascular disease is wrong. But circling back, because we see that it's a single gene on the nuclear envelope of a cell that changes and causes insulin resistance, profound insulin resistance. These people have lipodystrophy. They have abs, but they have visceral fat because they have insulin resistance due to their monogenic condition. They do not have elevated LDL, and they have massive aggressive atherosclerosis. So let's just
and
go
you
back.
also
What's that?
No, but real quick, you also have people with hypobeta lipoproteinemia. These are people with like no beta, LDL particles, VLDL, IDL. They have almost no atherosclerosis, depending on which gene is knocked out. You have no ApoB, you have almost no atherosclerosis. So I mean, we're probably talking about different populations with different things. But either way, I mean, we can go back and forth on this, but maybe you had some other topics you wanted to discuss too.
No, I have a lot of things. So let's just talk about that for a moment. I want to get back to veins and arteries because we got off track, but I do want to talk about that as well. But I think it's just important that we understand that what you are describing, I think, is one of the issues with Western medicine. And the reason that I think it's important we have this conversation. Because if doctors see patients with hypertension, obesity, low HDL, high triglycerides, and an impaired fasting glucose, and they don't consider those patients insulin resistant, we are failing our patients. All of those patients likely have some degree of insulin resistance and need a fasting insulin to be ordered. And so I think that we are blind to this epidemic of insulin resistance within our populations. And even the AHA, even the American Heart Association is blind to this. I have the same statistics that you have saying 10% of US adults have diabetes, 15 to 30% have prediabetes. And I think, no, you're wrong. It's 90% have prediabetes. We have an epidemic of insulin resistance. As those papers show repeatedly, that very few people have optimal metabolic health. And I would define insulin resistance as a continuum. And if you do not have optimal metabolic health, you have some degree of insulin resistance. And my contention is that if you have some degree of insulin resistance, you are at a higher risk of atherosclerosis, not because of your elevated ApoB, but because of the way those LDL particles, those ApoB particles, are retained in the arterial wall. But that doesn't mean that ApoB or LDL causes atherosclerosis. To me, it indicates that we might be making an error of judgment and that LDL gets wrapped into atherosclerotic plaques that are happening more aggressively because people are not repairing the endothelium because they have some degree of insulin resistance. This gets back to this veins versus arteries thing, but I'll just talk about this for a moment. So when I look at humans' arteries and I look at the inside of an artery, we know that the inside of an artery and a vein are essentially endothelium. And we know that in all of us, because we have higher pressure in the arteries, we are getting some damage at the bifurcations due to turbulence. And so what I believe is happening, my hypothesis for what's happening in atherosclerosis, is not that LDL is driving endothelial damage. There's really no evidence that native LDL damages the endothelium. There's potentially evidence that oxidized LDL within the intimal space can damage the endothelium once the LDL has been oxidized by a macrophage. But there's really no good evidence that LDL is directly damaging to the endothelium. And as we'll see in our conversation about veins and arteries, we must have an endothelial injury to initiate atherosclerosis. That is the proximate event of atherosclerosis. And so what I think is happening here, and the way that I think insulin resistance is related to all of this, is that in people who have some degree of insulin resistance, they're not doing wound healing well. We know that at the extreme spectrum, diabetics lose toes and they lose feet because of their impaired wound healing. We know that diabetics are increased risk of death from COVID. We know that obesity is a risk factor for COVID and all of these infectious diseases because their immune system doesn't work well. So my contention, my suspicion, my hypothesis here, the whole point of this discussion is to propose another theory of atherosclerosis that says, wait, what if LDL is not the right target? Because there's probably something else going on. What if endothelial damage is the originator of the atherosclerotic plaque, and it's only in people who are insulin resistant that atherosclerotic plaque begins to develop because that wound healing at the level of the endothelium is not proceeding properly. More of that LDL, more of that ApoB is retained in the proteoglycans in the subintimal space. That LDL is enriched in linoleic acid. I know we're going to get to that. Therefore, it's more likely to be oxidized and taken up by the macrophages and made into foam cells, made into these fatty streaks. But that's a very different position than saying LDL causes atherosclerosis, because I don't believe LDL causes atherosclerosis. I believe insulin resistance predisposes us to impaired wound repair at the level of the endothelium, and that is what causes atherosclerosis. And that just like wood in a fire, LDL is involved in that and potentially necessary for that, but doesn't initiate it. This is the necessary but not sufficient idea. So when you see kids with A beta lipoproteinemia and they don't have very much LDL and they don't have much atherosclerosis, I say, yeah.
Well, A beta, you would die.
Well, hypo, right?
Hypo.
So they don't have much atherosclerosis. That means, okay, you have less wood, you have less fires. You know, if you have less of the material that gets wrapped into the plaque, less of the LDL that gets oxidized in the subintimal space, you're going to have less atherosclerosis. But to me, just intuitively and philosophically, I think it's an error of judgment to say that that means that LDL causes atherosclerosis. I said a lot there. Does that make sense? Can I clarify any of that? Because that was
So let me just
summary of the way that I think about things. And I still want to get to veins and arteries.
No, I know we'll get to veins and arteries, but let me just tell you, I'm a preventive cardiologist. I'm also a weight loss doctor. I spend hours with each patient teaching them weight loss. I actually published multiple books on weight loss, how to lose weight properly without the madness that you read out there. But I even like become their friends on MyFitnessPal. I see what they're eating, what they're not doing. We add medications. Like, I'm not telling people that it's okay to stay obese and we'll just treat your hypertension or sleep apnea with a machine or what have you. We try our hardest to get people to lose weight. I know sometimes people criticize Western medicine. They say, you guys just give us pills and you don't really try to do lifestyle. That's not true for me, at least. I don't know how it works with other people. I literally spend hours with each patient trying to get them to lose weight, eat better, eat healthier, move more, what have you. We put them on meds if they need it to help lose weight, if they stall or what have you. So that is not me. I'm a bodybuilder. I'm a certified personal trainer. I teach my patients how to lose weight the correct way. Back up a little bit there. Metabolic health, I think the way you're defining it is a little bit different. Hypertension does not require insulin resistance. There are plenty of hypertensives, and we don't have to agree on it, but there are plenty of hypertensive, smokers, obese people that have no evidence of insulin resistance. I guess it depends on how you want to define it. But either way, I agree that the vast majority of Americans even if you want to go by the 73 or 83%, are overweight. No question about it. And that leads to a lot of things. Sleep apnea being one of the biggest ones, literally, hypertension, even if they have the genes for diabetes, obviously diabetes, what have you, all of those things. But ApoB, at the end of the day, if it was not elevated, those people would not have that. Now, getting back to endothelial damage, in the 1970s, we used to have this thing where we thought it was a response to injury, where we thought that the endothelium was injured, kind of like what you were saying. The blood pressure caused shearing, what have you, plaque formed, the cholesterol was the good guy coming to patch it up. We used to think that in the 1970s. We spent the next 20 years trying to prove that either correct or not. Scientists also have big egos and they want to prove each other right or wrong. So they've done a lot of studies since then trying to figure out why on earth, what happens. Do you need an injury? Do you need inflammation? Do you need to tear up the artery? And they've done the studies where they go in and actually damage the artery. It turns out it's not the places where the injury is, not the bifurcations. And I've done cardiac caths on patients. The vast majority of lesions are not at bifurcations. And I'm sure you saw them when you were doing, your thing with cardiology. They're straight lines. These arteries are straight lines, and you see the blockages. I mean, this is like a heart model. You see these straight arteries. It's not always at a branch point, and it wasn't that either. So they tested all these things for the next 20 years, and they found out that the difference is first of all, you had to have intact endothelium. That if you don't have intact, normal functioning endothelium, you cannot have atherosclerosis. They've gone in with catheters and scratched the endothelium and taken ultrasound, IVUS ultrasound pictures of it. The part that was damaged just scabbed over, healed. But next to it, the fully intact normal part is the part that got the atherosclerosis. So later in the 1995, 1996, they published this new theory. I don't know if it's a theory, it's probably proven at this point, but they published this new thing. So. Well, maybe not, but they published this new thing saying it's a response to retention, that the difference is not damage. It's not the good guy coming in to plug up the damage. You actually need intact endothelium. The difference is that arteries, and this probably plays into the arteries versus veins, arteries can actually hang on or retain lipoproteins. And that was the actual difference. So even though there's so many of these, they're going in and out through these 70 nanometer, gap junctions, even via transcytosis sometimes. All these different ways that these things are getting into your arteries, they get oxidized, they get damage in there. The immune system, macrophages, forms foam cells, and then you get this fibrous plaque. And then one day, I think I've showed the model here. You've got these plaque, and then one day a plaque ruptures. You've got, a thrombus here, and then it plugs up your entire lumen, and that's how you have a heart attack. Now, not everybody has heart attacks, but if you do, that's kind of the process. One of these fibrous, vulnerable, soft plaque ruptures, and that's what happens. Actually, calcified plaques generally are considered protective or not likely to rupture, but it does mean when you have a calcium score that's positive that you also have tons of soft plaque that hasn't yet calcified, but it's the soft plaque that's going to cause about 80% of heart attacks, 70 to 80, depending on the, paper you read, is what causes these acute MIs, the NSTEMIs and non-STEMIs and what have you. So that's why, and veins and arteries are very different. Arteries are very thick and muscular. I mean, just look at a cross section of what this looks like. This is very muscular. It has an endothelium, an intima, a media. Veins are like paper thin. They're completely different. And when you take an artery or a vein out of the venous system and bypass it in CABG, it arterializes. It actually gets thicker. It starts having atherosclerosis. It arterializes, and it starts having the same problem that the arterial side has. So I don't know if that touches on some of the things you were talking about, but that's kind of just my response to some of those things.
Yeah, I appreciate that. This is actually really important. We've sort of naturally arrived at arteries versus veins and atherosclerosis. So I also want to bookmark what you were saying. I think it's amazing that you are working with your patients to eat healthy and get healthy. I think that unfortunately, you and I are going to be recommending very different diets to people when they're getting healthy. I've heard you recommend seed oils to people on previous podcasts. And so unfortunately, we're going to have to talk about seed oils in this podcast and linoleic acid. And so I think that I applaud you for trying to help work with your patients to help them lose weight. I just think that when you and I, if you and I were to see a patient and to recommend a diet, those diets would be vastly different for people. And so I'm not saying that Western medicine, I mean, you're a good example of this, doesn't try to help people get healthy. I just think that predominantly because of this LDL issue and linoleic acid and seed oils, let me finish. predominantly because of this LDL issue and linoleic acid and seed oils, Western medicine is recommending very different things to patients than I think are actually healthy for people long term. So let's come back to that a little bit. But let's do arteries and veins. So
can I just throw in one little thing?
Yeah.
It's super short. It has nothing to do with that. But another problem is that a lot of patients finally come to Western medicine when they're far gone. I mean, there's a lot of population bias. The people that come and have to see a cardiologist have already had a heart attack, already had a stroke, already had open heart, already been overweight, hypertensive, smoker, peripheral artery disease for years. So for me personally, at least, I kind of see patients towards the end of their care. A lot of my patients are like, oh my God, I wish I would have met you 40 years ago. I'm like, yeah, me too. But part of the problem is the insurance system. They pay for, I mean, you know how the insurance system works in the United States. They only pay like to fix things, but they won't pay like for prevention. So I know they're trying to change that, but no, we can get back to what you were saying.
So let's get back to arteries and veins. So everything we've said aside so far, if it's been too complicated for people, if we believe that LDL cholesterol or ApoB containing lipoproteins, we're sort of using those terms interchangeably in this podcast, cause atherosclerosis, then the question that I have offered to many cardiologists and that I think is a very interesting discussion point is, why don't we get atherosclerosis in the native venous circulation? And I'll expound on that question so people understand why I'm asking it, and then we can talk about it. There is the exact amount of ApoB in the arterial circulation and in the venous circulation. It's continuous. So if you have an LDL-C or an ApoB of 100 or 130 or 200, you have the exact same amount in your veins, right? And the inside, which is really the only part that counts because these are all circulating in the vessel, the inside of a vein looks just like the inside of an artery. They both have the exact same endothelium. You're disagreeing with me, but I'm going to just debate you on this. I'm going to show a picture here. The inside of a vein is exactly the same as the inside of an artery. There is no difference in the interior anatomy. Now, if you want to talk about the arterial wall versus the vein wall, that's true, but you can look at the histology. This is not really able to be argued. The endothelium of an artery is exactly the same as the endothelium as a vein. There's a subintimal space in an artery. There's a subintimal space in a vein. There's an adventitial layer here. The only difference here, or the main difference, is that the artery has a muscular layer because it contains more pressure. But the inside of an artery and a vein is exactly the same. And you spoke to this earlier when you said that if you put a vein into the arterial circulation, it accumulates atherosclerosis because it has the ability to become atherosclerosed because the endothelium is the same in an artery and a vein. The fact that it arterializes and becomes more muscular on the outer layers doesn't really affect the atherosclerosis. We believe, I mean, if you're talking about the response to retention hypothesis, there are those who disagree with this. There are those who believe that LDL actually arrives in the subintimal space from the vasa vasorum, which is the blood supply to the muscular part of the artery or the vein. But the fact that veins are thin doesn't mean that they can't get atherosclerosis. You even said that when a vein is transplanted into the arterial circulation, it will become atherosclerosed. And I think that you can tell me if you disagree with this, but if you were to take an artery and put it in the arterial circulation in a cabbage, or a vein and put it in the arterial circulation in a cabbage, a vein breaks down way faster. When I was in cardiology, if you could get an artery and put it in the arterial circulation, then that would last longer in a cabbage, in a coronary artery bypass graft, you're nodding, you're agreeing, than a vein. And so we know that I think it's a pretty strong statement to say that veins will become atherosclerotic more quickly than arteries. So why is it that if a vein is more susceptible to atherosclerosis, then an LDL supposedly causes atherosclerosis, and that arteries and veins are exposed to the same amount of LDL, that we don't get atherosclerosis in the native venous circulation? This, to me, is perhaps the most interesting conundrum of the LDL causes atherosclerosis argument. And you said it's retention. Well, there are proteoglycans in the subintimal space in a vein as well. We know that. If you put a vein into the arterial circulation, it can retain LDL. So there's no reason that a vein couldn't retain that LDL. It has proteoglycans in the subintimal space, just like an artery does. So it can retain, it has the endothelium that looks exactly the same, and it should be getting atherosclerosis in the native circulation if LDL or ApoB, which most of the mainstream medical system says causes atherosclerosis, is actually the proximate cause of atherosclerosis.
So there's a lot going on there for whatever reason. And I don't know that we don't understand everything in medicine, obviously, but for whatever reason, arteries are able to retain LDLs. You like you said, you have 1,600 particles floating around on your arterial side, venous side. They're small enough where they can get in everywhere. But for whatever reason, the proteoglycans, the glycocalyx, the macrophages, what have you, for whatever reason, the arteries decide to retain it. You are correct that the arteries, if we can get a radial artery and transplant that into a bypass, it does last longer than a venous graft. Venous grafts do arterialize, not exactly the same way, but they do get thicker because, you are putting them into a pressured, much higher pressure system. So they do get a little bit thicker. They don't like completely turn into arteries, but they do end up with, atherosclerosis similarly, like a artery would. But for whatever reason, and I don't know that we know the full answer, arteries can retain these LDLs and then they aggregate, they stick together. It's probably like the cytokines and these, markers, these, things that signal for them to stay there or get moved around or what have you. I don't know what
the veins do it too.
But they're different, structures. I mean, a vein, if you look at it under microscopically, it's a very like paper thin wall, whereas an artery is like super thick. Right. I mean, but still, they're completely different.
They're not completely different. I just showed you the anatomy. They're very similar. They have.
The anatomy looks normal on a cartoon picture, but they're completely different. One side has very high pressure, capability. The other's a much lower pressure system. They're completely different structures.
They're not completely different. They both have endothelium. They both have submental space. And if you put a vein into the arterial circulation, it can become atherosclerotic. So we know that a vein possesses the ability to retain LDL and ApoB. It's not that arteries are the only ones that can retain ApoB. Right. Veins can retain ApoB too. They just don't do it.
But once you put it on the arterial side, the signaling, the chemical signaling, the cytokines, what have you, that's probably part of the equation. I mean,
we don't know.
So it only makes sense.
There's no answer there.
I mean, no, there is an answer. I mean, we know that this happens in arteries. The question is it all defined or why? There's lots of reasons. For whatever reason, arteries like to retain it. They've done studies and they've tried to figure out, is it this, is it that, why does this happen? We have a lot of the answers. We don't always know anything. Anybody who tells you with absolute certainty, this is how it is probably not 100% accurate. There's a lot of nuance, like you said. So I think we don't know all of the answers to that one. But for whatever reason, arteries like to retain LDL and then they aggregate, they get oxidized, the macrophages attack them, it becomes foam cells. On the venous side, they're floating in and out, but it doesn't happen. It's a completely different structure.
It's not a completely different structure. It's a very similar structure that can retain ApoB. We know it has the ability to retain ApoB. And I think that...
But they don't.
My point, they don't exactly because LDL does not cause atherosclerosis. Because LDL is not enough to cause atherosclerosis. I mean, that's the point.
You're jumping through hoops there.
No, I think you're the one who's jumping through hoops, respectfully here.
Maybe I am.
I mean, it's like,
but either way,
if LDL were enough to cause atherosclerosis, then it should cause atherosclerosis in a vein. Because we know
it's not the LDL only. I mean, there's a lot more to it. Like the LDL, you could put it anywhere, but it has to actually be retained. It has to aggregate. It has to get damaged and oxidized and taken up by macrophages. I mean, it's a whole long process. It's not like we just throw an LDL somewhere and suddenly, magic happens.
Well, that's what you were saying at the beginning of this podcast. You said the more LDL, the more atherosclerosis. All of these studies
because everybody has arteries. I mean, and has a chemical milieu.
All of these people say LDL causes atherosclerosis. They don't say LDL plus something else causes atherosclerosis. Their target is LDL. Their target is ApoB. Right. And I would say
because if you take away that one step, let's say it's LDL plus the the proteoglycans plus cytokines plus whatever inside the arterial wall. But if you take away the LDL, the rest can't do what it's supposed to do. You end the process. And that's kind of what we found with all the studies.
That doesn't mean that LDL causes it. That's a logical fallacy. If you want to look at it that way, fine. You can't have fire without wood, but wood doesn't cause a fire. You need a spark. So this is what I'm talking about.
Right. So the fire causes the fire. You need the fire to start the fire.
You need the wood to cause the fire, right? You need LDL to get involved in the plaque. But this is where I think things start to break down. You're seeing my arguments here that LDL doesn't look like it's enough to incite atherosclerosis. I'm not denying that LDL is correlated with atherosclerosis, especially in the majority of the population that are insulin resistant. But to say that LDL causes atherosclerosis is,
But
in my opinion, false. You cannot corroborate that assertion with Western medicine.
I mean,
the judgment error that people are making.
The studies have been very clear. If you don't have LDL, and I don't care how you lower it, if you're born without it, if we lower it, if you suck it all out with like a plasmapheresis, an LDL lipoprotein pheresis, whatever, if you suck out with like a dialysis machine,
sure,
you end up with no atherosclerosis. Now, it doesn't matter what the next steps are, but like if I take away the spark from the fire or the wood or what have you, you end up with no fire. I mean, it's kind of saying the same thing in a different way.
But this is a really, really important point. Necessary, but not sufficient. LDL causing atherosclerosis is different than saying LDL is involved in atherosclerosis. Just because taking away LDL and not seeing atherosclerosis doesn't prove that LDL causes atherosclerosis. It doesn't prove it. Taking away wood from a fire, you can't have a fire, but wood doesn't cause a fire. Wood doesn't spontaneously combust into a fire. It needs lightning.
Sure.
It needs a spark. There has to be a proximate event. And that is what we are missing in Western medicine. There's no proximate event in this theory. LDL doesn't cause atherosclerosis. It's not enough to cause atherosclerosis. Just saying that you can take it away and you'll not have atherosclerosis proves that it's associated, and I've never debated that, but it doesn't prove that it causes it. And this is why I think we have the wrong target and we're not doing as good for our patients as we could be, because I think we should be focusing on insulin resistance and other things that are clearly or more clearly indicted as causal in atherosclerosis. And the reason this whole thing, I'll just say this and then I'll let you talk as much as you want. The reason this whole thing is so important is because in the 6.8 or 12.2% of the population who are metabolically healthy, sometimes eating red meat with saturated fat raises your LDL, but you remain metabolically healthy. My fasting insulin is less than 3. I'm not sure if you check your own fasting insulin. Do you know what your fasting insulin is?
4.
So it's 4.
It's 4.
So you're insulin sensitive too. This is great. So in insulin sensitive individuals, right? If you raise the LDL by eating things that I believe are healthy for humans and evolutionarily consistent, I don't think that's a big deal. And I don't think we should dissuade people from doing that, because I think the most important thing we should be focusing on is insulin resistance rather than the LDL with these nuances. This is where I think the totality of the evidence leads us wrong, leads us astray.
So just to summarize what you're saying, and I agree for some of it, like LDL has to be there. I think you're agreeing with that, right? Without LDL, you're saying the spark has to be there, right? Or
no,
what have you?
LDL in my metaphor is the wood.
Oh, okay. On your side, it's the wood. So something has to be there. Let's call it LDL. The LDL has to be present in order for atherosclerosis to occur. You're just arguing what might spark it. Right?
Exactly. Because if we extend the metaphor, and perhaps this is an overextension of the metaphor, but I don't think so. Wood is valuable, right? Wood can be used to build houses. Wood can be used to build shelter, and that is valuable. Wood can also turn into a fire, which burns a forest down. So wood has value. And similarly, LDL particles, ApoB containing particles, have value in the human body. We know that they're associated with an immune response. They interfere with quorum sensing with bacteria. We can get into the literature suggesting that lower levels of LDL are associated with increased hospitalizations. I know that there's contentions around that, and we can get into the details if you want. But 85-year-old plus in the Leiden 85 study live a very long time with the highest levels of LDL. We know that LDL, it's very difficult to debate that LDL particles are involved in the immune response. LDL also moves building blocks around the body. LDL is valuable, I would contend, for delivering triglycerides, delivering cell membrane components. We know that both the components of the LDL, the triglycerides, and the cholesterol are involved in cell membrane building, involved in precursors for hormones. All of this bodybuilding you're doing, you need hormones that are moved by LDL. Wood has value. Wood builds houses. LDL has value in the human body, okay? But LDL can become involved in problematic processes. Wood can start a forest fire. It doesn't mean that wood causes the forest fire. It doesn't mean that LDL causes the forest fire. This is it's an error of judgment. This is a logical fallacy. And this is what I'm saying, is that I think we're missing the target and not doing as well for people as we should be. I think there's a more important target to focus on. And the best thing that I've ever seen throughout all of this is insulin resistance. And as we talked about, I think that Western medicine is grossly underestimating the proportion of people that are insulin resistant. And so we're leaving millions, hundreds of millions of people out in the cold, symbolically speaking, we're leaving them at the risk of higher cardiovascular events by not focusing on their insulin resistance and not understanding what causes their insulin resistance and not trying to help them treat that. That, I think, is where the problem is. And that in the 6.8, 12.2% of people who are insulin sensitive, if they eat meat, if they eat organs, if they eat butter, if they eat whole milk, preferably raw, right? And there's lots of good evidence that dairy fat, whole dairy saturated fat, is associated with improved cardiovascular outcomes, or no evidence of harm from butter, dairy,
neutral,
and butter fat.
Neutral to protective.
Neutral to protective, yeah. So you're agreeing, neutral to protective, right? If they're doing those things and the LDL goes up, I do not believe that we can say that is an increased cardiovascular risk. And that is the point of this discussion. I think that's where the totality of the evidence leads us astray.
So just a couple points. So I think your definition of metabolically healthy and insulin resistant are a little bit different. So people have hypertension and obesity and smoking and all these other things. They don't have to have insulin resistance, but you're lumping that all into it, which is fine. That's your definition. It's not a big deal.
Smoking, yes. Obesity, no. I believe people who are obese have insulin resistance. I believe someone with...
Not all of them. I mean, I have 400-pound patients that have like no issues with insulin resistance, blood sugars, none of that.
Resistance? How are you?
I mean, the same way, A1C, fasting glucose, the usual markers.
Fasting insulin. That's what we're missing. Fasting glucose.
But you have to correlate that. You have to correlate that with their fasting glucose. I mean,
no. Fasting insulin, I think, that is a dead clear metric of insulin sensitivity. That is the best
you could use that, but we don't always have.
It's inaccurate. A fasting glucose doesn't give you a full representation of
fasting glucose gives you a very accurate
postprandial glucose spikes. You can look at a CGM.
Postprandial is very good.
No, I've seen it over and over that people have a normal or only slightly elevated fasting glucose and they can have an elevated fasting insulin. This is the whole point of a CGM.
So we can leave that alone. But either way, my point is, and we're not disagreeing. Most of these folks that have these problems, they do need to work on them. Don't get me wrong. People need to lose weight. They need to quit smoking. They need to eat a healthier diet. Absolutely. That's kind of been the biggest crux and problem in the United States. And, most modern countries now have similar problems where we are getting all of these chronic illnesses, partially genetic, but a huge amount of it coming from lifestyle choices. What you're eating, how much you're eating. Yeah, but you have to have the genetics for some of these things. Like you can't just make yourself. Yeah, but you can't just make yourself insulin resistant by like becoming 500 pounds. That's just not, it doesn't happen.
Of course you can. You can. You can absolutely make yourself.
You can't actually.
Yes,
you need to have the genetics for it.
No,
Type 2 diabetes there's 17
Are you telling me
alleles.
there's a 500-pound person on this planet who's insulin sensitive?
Yeah, I've seen some of them. I mean, there's not a lot. Don't get me wrong.
No,
but
I think that we would have to have a much deeper debate about how we're actually assaying insulin sensitivity. I don't believe there's a 500-pound person on the planet who's insulin sensitive. Certainly not optimally metabolically healthy. No way. And I think
they have other problems. They have sleep apnea. They have obesity, hypoventilation. They have hypertension. They might have all these other things. But there are people who are very overweight that are not insulin resistant whatsoever. I mean, that's
I would disagree with you. I think that that's
all over the literature.
I think we're missing insulin.
So look, Paul, if you have no genetics for type 2 diabetes and you ate 300 jelly donuts a day and got to 240 pounds, can you make yourself insulin resistant?
Absolutely. A 240-pound version of Paul
you have
is insulin resistant.
No,
Absolutely.
you have to have the genetics for it.
Okay,
we don't have to agree on that either, I guess.
No way. I think some people are going to have other problems before they get diabetes. I think some people are going to have massive autoimmune disease, or they're going to have osteoarthritis, or they're going to have hypothyroidism, or they're going to have eczema, they're going to have psoriasis, or they're going to have depression or dementia, or they're going to have cardiovascular disease before they get diabetes. Well, I actually don't believe you can have cardiovascular disease without diabetes. So I think that this is the problem.
But Paul, I think.
Wait. Let me finish. But I think that on my way to a 240-pound version, I'm 5'10", 170 pounds right now. My body fat is probably 10%, right? Like on my way to a 240-pound fat version of Paul, absolutely, I'm going to get insulin resistant. Absolutely. I mean,
if you have the genes for it, sure.
There are some people who are going to have extreme genetics for diabetes. We see this with incidents of people like the Pima Indians who are going to get diabetic very quickly. We know there are people who have insulin resistance who are not even obese, right? But I believe that I would make this statement strongly, and I will die on this hill. There are no obese people in this country who are not
Please don't
resistant.
die.
There are no insulin resistant. There are no obese people in this country who are insulin sensitive. That is false. And I think this is really important because it indicates where our blind spot might be in Western medicine. If cardiologists are being trained and we're not looking, by we, I mean you, because you're the cardiologist, I'm not a cardiologist. If cardiologists are being trained and we as a medical group of physicians are not looking at insulin resistance more carefully, and we're seeing obese people or people with hypertension or people with high triglycerides and low HDL and not realizing they're insulin resistant, man, we can do a lot of good if we fix those people. But then the critical question becomes how we fix insulin resistance. And we can talk about that. That's probably the next part of this podcast, which we'll get to in a moment.
Right. So I agree with you that we're not doing a very good job of helping these people. But first of all, it's like these people are not also doing a good job of helping themselves. Like as a cardiologist, people come to me after the fact. I did not see them as a primary doctor, as a primary nurse practitioner, where I saw them when they were 15, 20 years old. I have 15, 20-year-old patients. They have like cholesterols of 5,000. I get those, but like a usual patient that comes to me is not 20 or 30 years old. That's like, hey, I don't want to ever need to see you. Please help me. It's after the fact. So I agree with you that as a country, as a society, as whatever, we aren't generally doing a good job of helping people not be overweight. Clearly, every year it goes up. Hypertension, smoking has gone down, but people are vaping now. So that's a huge problem. But we're not doing a good job with that. I agree on that part. I think maybe you're overstating insulin resistance a little bit. Maybe we disagree on how we define it, but that's fine.
Let's talk about seed oils, because I think this is the next segue. Sure. And I think this is another place where we disagree pretty significantly. So I've heard you say on other podcasts that seed oils are not bad for humans, and there's no evidence that seed oils are harmful for humans. And so I want to show, you've said publicly, like, show me a human trial that shows that seed oils are bad for humans. And by seed oils, we're really talking about linoleic acid. So I want to show my contention of multiple human trials, and I'm not going to show any of the ones you don't like. We're not going to get into Minnesota or Sydney or any of these we're not going to do any of those trials. I'm going to show you other trials, right? Because all that discussion has been done before. Tucker Goodrich, like, we've debated with people on this in the past. I don't think it's worth arguing over the validity of Minnesota Coronary, Sydney Diet Heart, LA Veterans, the margarine trial. I want to show you other studies that you may or may not have seen that will suggest that in humans, linoleic acid and seed oils containing linoleic acid are problematic. If you look at the literature, there's evidence that there's increased LDL oxidation when there's increased seed oils, increased linoleic acid. So we've already talked about linoleic acid, LDL oxidation, and the idea that oxidation of LDL in the subendothelial space is probably a very bad thing. So in the Jerusalem nutrition study, people that were eating more seed oils had more LDL oxidation. We know that when more linoleic acid is consumed, there's increased LA breakdown products. So there's increased 4-HNE, 9 and 13 HODs. When less linoleic acid is consumed, there's less linoleic acid breakdown products. And we know that when there's more linoleic acid in the LDL particle, that particle is more susceptible to oxidation. Increased saturated fat, the fat that raises LDL, which the mainstream believes causes cardiovascular disease, will decrease Lp(a), a very strong risk factor for cardiovascular disease. Decreased saturated fat and increased linoleic acid will increase Lp(a) and will increase oxidized LDL. So increased linoleic acid decreases male hormones. That's testosterone and testosterone byproducts. I'll show that. There's a study in humans showing that soybean oil consumption increases Lp(PLA2). So lipoprotein phospholipase A2 is a particle that's associated with LDL that is involved in cleaving oxidized phospholipids in LDL. So that's probably not a good thing if you're increasing Lp(PLA2). We know that in people, this is observational, there's a strong, consistent correlation between linoleic acid consumption and macular degeneration. And we know that in mothers who are breastfeeding, the LA content, so the linoleic acid content of the breast milk, correlates negatively with motor and cognitive skills in kids. The last piece of this is that in studies that look at linoleic acid, and this is probably why linoleic acid is so confusing, consistently researchers are looking at serum levels of linoleic acid, when in fact the only seriously good metric that will reflect linoleic acid consumption in the diet is adipose tissue linoleic acid. I know there was a large study that you posted on Twitter looking at linoleic acid in the human diet and cardiovascular disease. And I can show that study if you want. I have the reference. Unfortunately, if you look at that study, of all the studies they looked at, only 1 or 2, maybe 3 max looked at adipose tissues of linoleic acid. And in none of those studies was there any significant association between adipose linoleic acid and improved cardiovascular outcomes, meaning more linoleic acid improves cardiovascular outcomes. And there are studies that show increased linoleic acid in the adipose tissue and worse cardiovascular outcomes. So this whole linoleic acid thing and the whole seed oil thing is very complicated and really interesting, because ultimately what you find is that if you're eating saturated fat from steak or butter, you're going to have more LDL, but you're also going to have less Lp(a) and less oxidized LDL. And if you eat seed oils, you're going to have less LDL. But I think that the cardiology community is missing the fact that you have increased Lp(a), and I can show you studies to corroborate any of these or all of these assertions. I'll show a couple just to show them in a moment. You're going to have increased Lp(a) and increased oxidized LDL. So we are missing the boat in a big way when it comes to saturated fat versus polyunsaturated fat. So let me just show a couple of studies to corroborate all of those things I said. So let's start with, here is a study in humans, decreasing saturated fat and increasing seed oils, increasing linoleic acid, increases oxidized LDL and Lp(a). So I don't think there are any cardiologists out there who would say that increasing oxidized LDL and increasing Lp(a) is a good thing. So saturated fat intake decreased, polyunsaturated fat increased, and they say alterations in dietary fat resulted in increased plasma concentrations of Lp(a) and oxidized LDL. So this is a study in humans showing inflammation. I believe that you could say that Lp(a) and oxidized LDL are indicators of inflammation. And these are bad cardiovascular outcomes with the seed oils. And I'll show a couple others just to corroborate this. We can go back to any of these if you want. So let's look at this one. Linoleic acid in the breast milk in kids. This one is particularly scary because I think that it's really dangerous to think about mothers eating too much linoleic acid and the way that it would affect their children. So title of this study is The Association Between Linoleic Acid Levels in Colostrum in Humans and Child Cognition at 2 and 3 Years in the Eden Cohort. So this is an article. Again, you were saying, show me articles in humans that seed oils or linoleic acid are bad. Our findings suggest that too high levels of linoleic acid in the colostrum are associated with poorer child development at 2 and 3 years. I want to show one more study. Again, I can show studies for all of the points that I just said. Let's look at the male sex hormones here as well. Diet and sex hormones in healthy men. If you look at this study, you'll find that with the inclusion of seed oils, increased linoleic acid, you see decreases in male sex hormones. Whether you're a man or a woman, you don't want that. I'm happy to show macular degeneration. I'm happy to show increased oxidized LDL with linoleic acid. I'm happy to show lowering linoleic. Actually, let me show this one because it's so important. So lowering dietary linoleic acid decreases oxidized linoleic acid metabolites in humans. These are things like 9 and 13 HOD. These are not associated with good outcomes. So it's pretty clear, I think, in humans that when we eat more linoleic acid, as more seed oils, things like corn, canola, sunflower, safflower, soybean, peanut, we're going to accumulate that linoleic acid in our adipose tissue. That's the only real indicator of how much linoleic acid we've consumed. We're also going to accumulate that linoleic acid in our LDL particles. And I can show an article or multiple articles clearly showing that LDL enriched in linoleic acid is more likely to be oxidized into the subendothelial space. So wrapping all of this back around, and I appreciate you letting me talk about all this. There'll be a lot for you to respond to, and I'll give you the floor in a moment. Wrapping all this back around, when we have LDL in the subintimal space, that LDL that's enriched in linoleic acid because people are eating seed oils is more like a bomb. That LDL is much more likely to become oxidized by the macrophage environment, more likely to become oxidized LDL. One thing that I didn't mention earlier in this podcast that I probably should have is that Brown and Goldstein many years ago clearly showed that macrophages don't take up native LDL in the subendothelial space. They only take up oxidized LDL. And so, again, I don't understand why LDL is a target and not oxidized LDL or things that increase the oxidation propensity of LDL. Those seem like the real problems here rather than LDL itself, when macrophages won't even take up native LDL. So, and if you want to show the study that you have that's showing linoleic acid is not bad for cardiovascular, I can show it. I have it as well, but we can talk about the adipose tissue and why I don't think that study is terribly compelling. So with all of that in mind, why in the world, my friend, and I feel like we're friends after this so far.
We are friends.
Why in the world, my friend, would you recommend that people eat seed oils and not just eat butter? I mean, you and I have to have a steak after this. Come on.
I will be more than happy. Look, so let me just tell you, I am not a vegan or a vegetarian. I love ribeyes. I make them myself. I'm a food snob. I even have like a cookbook that includes like food. I don't mind putting butter on my steak. I don't eat it every day, but I'm not one of these. But also my LDL is like 46. So either way,
wait,
just to get back to it. And
you take meds?
I do. I take Zetia and Crestor.
Okay.
It's like 41 and 46 ApoB and LDL.
Okay, so you're taking medications to lower your LDL. That's just we need
right.
We need to be transparent about that.
Absolutely. Yeah, that's not a problem. All my folks know this. But yeah, we are friends. I mean, people who are watching this, I don't want you guys to think we're like having a fight or an argument here. We're all friends here. We all have the same goals in mind. Everybody who works in healthcare is trying to help people get healthier. We may reach different conclusions. We might reach different ways of achieving the same goals, which is fine. You know, at the end of the day, I think our intentions are both to help people get better. I know I've talked to Paul before this. We both have that same goal in mind. The study that I usually cite, which I feel is the most conclusive, was a 2019 Circulation publication.
Let me pull it up.
They had 68,000 participants.
Let me pull it up so we have it. Hold on one sec.
Yeah, fine. Well, let me just bring it up. You can pull it up, but let me keep talking. Does that work? So they had 68,000 participants in this trial. They followed most of them anywhere from 2 to 31.9 years. The endpoints were reached 15,000 times. They had 76,000 fatty acid measurements. So they actually like biopsied and, did testing on the people. They had 76,000 samples.
Well,
you can respond in a second. And ultimately, the conclusion of this almost 70,000 person, 76,000, biopsy study was that seed oils or however you want to measure linoleic acid, it was actually more specific, had a reduction in CV mortality and strokes. Now, we know that consumption of seed oils has gone up. It's a cheap oil. Of course, it's easy to make. And we've had, since that happened, like that was the 1960s, since the 1960s until now, we've had a 60% reduction in cardiovascular deaths. You may argue it's the medications or the stent technology, what have you.
But
that's fine.
We have increasing morbidity. So
I know, but just let me just talk too, and then you can jump in. The linoleic acid that we found has been shown to reduce total cholesterol and LDL. Now, this is especially true in most studies, and you said this too. When you take saturated fat and substitute it out for any PUFA or MUFA, monounsaturated, polyunsaturated fatty acids, you do get reduced LDL cholesterol, total cholesterol, and improved outcomes. Now, look, I'm not like married to seed oils. I don't even know how I got wrapped up into this seed oil business. I love olive oil, fresh, cold pressed, extra virgin olive oil. That's what we use. I came from a Mediterranean part of the world. My grandparents and my dad actually grew up on an olive tree farm. The olives from there and the oil that they made was amazing and fantastic. That's what I grew up consuming, and that's what I recommend to most of my patients. But not everyone can afford like the highest level of olive oil. If you substitute it for any vegetable oil, it would be fine. The vast majority of people, if they're downing like sticks and sticks of butter every day, that's going to be a problem. No one is telling you to do that. You can eat a little bit here and there, not a big deal.
I'm telling him to do that.
I know. Yeah, I know your stance. But if you switch butter out to anything, like whether it's olive or safflower, canola, whatever, I don't care which one it is, anything that's unsaturated, polyunsaturated, mono, you see improved outcomes. Literally every study has done that. But this was just the biggest study that was done on linoleic acid with tissue biopsies, tissue samples, and what have you.
Yeah. So if you actually look at the study carefully and you look at the ones that they included, and I'm trying to pull up the study so I can show people, there were very, very few tissue biopsies. So adipose tissue linoleic acid is the only accurate measure of linoleic acid in the human body. And I'll talk about why. And so of all the studies they included in this, only 2 or 3 of the potentially 30 plus studies looked at adipose tissue linoleic acid. And in those 3 studies, there was no correlation. There was no protective benefit of linoleic acid for cardiovascular disease.
You were saying something about the tissue biopsies, the 76,000 tissue biopsies. What were you saying?
There were not 76,000 tissue biopsies in the study. There were only
that's what they said.
There were only 3 studies of all the studies they considered that were adipose tissue linoleic acid. The majority of studies in this reference are looking at linoleic acid levels in the serum. And the reason linoleic acid levels in the serum are not accurate is because lower levels of linoleic acid can be found in people with increased levels of cardiovascular disease when that linoleic acid is oxidized into oxlams, oxidized products of linoleic acid metabolism, 4-HNE, 9 and 13 HOD. And so if you really want to understand how much linoleic acid someone is eating, you must look at adipose LA. And of all the studies they considered in this one, only 3 looked at adipose linoleic acid. And of those 3, there was no protective benefit of linoleic acid when it comes to cardiovascular disease. So this is an error of human physiology that is so often made in linoleic acid literature that you cannot look at serum levels of linoleic acid. You must look at adipose tissue linoleic acid. And as I said, there are studies, there's one that I can show if you want, that shows more linoleic acid in the adipose tissue, worse cardiovascular disease. And so I think that, again,
you
the Western medical system, let me finish this one. The Western medical system is missing the mark here. Even though this is a big study with lots of patient outcomes, they're looking at the wrong markers. You can't use serum linoleic acid. You have to use adipose tissue linoleic acid. That's what you have to use. And this study didn't use that. And they didn't do 76,000 biopsies of people's adipose tissue. There were only 3 studies of all of them that had the actual level of adipose tissue LA. They were mostly looking at serum linoleic acid, which is inaccurate, as I said. It doesn't reflect linoleic acid consumption. We know that. That's been shown over and over and over. That's human physiology. We know that linoleic acid can be metabolized into all sorts of things, arachidonic acid. And oftentimes, if you have more linoleic acid in your blood, it means that you don't have inflammation because that linoleic acid is not going down that omega-6 pathway. So this linoleic acid in the blood is a very mushy, very inaccurate measure of linoleic acid consumption. So this is where I think we go wrong. Did you want to respond to, like, what about all those things that I showed you about more linoleic acid, increased oxidized LDL, more linoleic acid, increased LP(a), more linoleic acid, worse child development, more linoleic acid, worse male hormones, more linoleic acid? It's endless. Like, how do you account for all of those?
Like a lot of those were, like 309 children, like, little small studies and measurements, which it doesn't matter. Like, I'm not like the defender of seed oils. I really don't care that much about it. I recommend for people to use olive oil, and I'm sure you do too, or butter, what have you. I'm not a huge advocate for butter, obviously. But, when you look at the totality of this one study, and this is the biggest, largest human study on this, they had 76,000 fatty acid measurements, and I didn't look to see if they're adipose tissue versus muscle, because I know some of them were muscle biopsies. There was some of them that were muscle biopsies, because I remember I did look at some of those. But either way, you can't argue with the outcomes. They had less cardiovascular disease, less cardiovascular mortality, and CVA, strokes. And their conclusion was that switching from saturated fat to any seed oil, whether, especially in this one, it was linoleic acid specifically, is cardioprotective. That was literally the outcome that they came up with. And we've seen over time with multiple studies that anytime you switch from a more saturated fat, like the line between saturated fat and cardiovascular death is a straight line.
No, it's not.
I don't think we are. We're not arguing that. You've said that on multiple podcasts yourself.
I'm definitely going to argue with you on that. The line between saturated fat and cardiovascular disease is a straight line. There's so many studies that come out. We just talked about earlier in this podcast.
It's exactly like this.
We talked about in this podcast, all this recent meta-analysis with saturated fat and butter. How do you account for the total allowance, the ketones?
So here's the thing. If the problem with saturated fat is it's on a sigmoidal curve. And I'll send you the studies if you want. But if you take saturated fat intakes of 30% of total calories and reduce it to 12%, you're not going to see a decrease in cardiovascular mortality, cardiovascular disease, cardiovascular anything, all-cause mortality, nothing. Because it's not enough. You haven't crossed the threshold. And there are studies that are published like that they're in JACC. They're in the Journal of the American College of Cardiology. There's a recent study in October 2019. It was like, saturated fat is not a concern anymore because look at this study. We reduced saturated fat intake from 20% down to 18, or like from 30 down to 15, and nothing happened. And we also know on the other side of the curve, saturated fat intakes below about 7%, there's no change in outcomes. If you go from 7% down to 3%, which is impossible to do, but you can, it's very difficult to show a reduction in cardiovascular mortality or what have you. But somewhere around the 8% mark, you have like this inflection point. Oops, the microphone. You have an inflection point where everything goes up. Like you have, 0 to about 6-7%, no change, huge inflection point to about 10%, and then everything above 10% is a flat line. So there's that. There's the Finland trial, or the North Korea, Finland. where they had the highest mortality rates in the 1970s. Cardiovascular mortality in North Karelia, Finland, there was 100 people, 700 people dying for every 100,000 people. So the country said, "Hey, what's going on here? Let's fix this." They sent out a bunch of educators to this one little urban town up in North Karelia, northern Finland, and they looked at everything they were doing, and these were like rural people, tons of butter, tons of milk, tons of fat, steak, what have you. And they said, "All right, you guys got to quit smoking. We got to try to lose some weight, and we're going to get your blood pressures down," because they had really high blood pressures, "and we're going to cut saturated fat intake." So they took their saturated fat intake down from 23% down to like 10 or something, like, somewhere around 10%. They had an 84% reduction in overall mortality over the next, decade or two, and it's still ongoing. They attributed 40% of that to the reduction in saturated fat intake, and 20% of that to the reduction in blood pressure. More people actually got overweight, obesity rates went up, and smoking rates came down a little, then in women went up a little, and then like dipped a little and have been going down, but people are like vaping and doing other things. But either way, I think the evidence for saturated fat in light of all that, and you said it on one of your own podcasts, that, we're not arguing saturated fat doesn't raise your LDL. Absolutely it does, no question.
That's not what I'm saying.
I think that, well, what are you saying? Tell me.
Yeah, that's what I'm saying. Like, saturated fat doesn't raise your LDL. I'm not arguing that saturated fat doesn't raise your LDL. What I'm arguing is that saturated fat, while it raises your LDL, decreases your oxidized LDL, decreases your LP little a. I think it's kind of shady to look at a Finland study where they had 4 interventions and they're trying to get people to lose weight, exercise more, decrease smoking, and lower saturated fat, and try and use fancy statistics to tell me that one of those is better or worse. There are free living populations of people all over the world. I'll show you these studies: Tokelauans, Katavans, Polynesian Islanders, who have huge amounts of saturated fat in their diet. This is the Stefan Lindeberg work, and essentially no evidence of vascular disease. So there are hundreds of thousands of people, natural experiments all over the world. There's no evidence that saturated fat is bad for humans. It's something we would have eaten evolutionarily.
But isolated societies, like if somebody's on an island and they've, evolved to eat what they have available to them, that's a different story. But like people in America and Europe maybe did not evolve those genetics, and, there was no survivorship bias or what have you. So they don't have the ability to eat that way. I'm sure there are these weird little pockets of people that can eat a certain way.
It's
but regardless,
but I think that that's unlikely.
I mean, how else do you explain, how else do you explain the direct line between saturated fat and death? I mean, cardiovascular death.
Where is there a direct line between saturated fat and cardiovascular disease? Wait. I need to go. We need to dig into the saturated fat a little bit. Let me show the butter and saturated fat study. So this is something we talked about this earlier in the podcast, and you did not disagree with this. So if you disagree with this now, I need to show this. So a systematic review, meta-analysis of butter consumption.
Butter is different than milk.
Well, butter is full of saturated fat, and the risk of
I know,
cardiovascular disease, diabetes,
but for whatever reason, dairy milk and fermented certain cheeses in women, for example, were shown to be either neutral or slightly cardioprotective, but not butter. I mean, that's not one of them.
It's right there. It's in this study. Meta-analysis of butter consumption, risk of cardiovascular disease, diabetes, and total mortality. Right there. Look at the conclusion.
But Paul, we can't just look at the title of a study that it looks like an N of 9 or what have you.
Systematic review, meta-analysis.
Nine participants. Paul,
this is a meta-analysis. 9 databases. It's not 9 participants. This is 9 databases. 6.5 million person years.
Well, you're scrolling through fast. But either way, you can find a study to prove like almost anything you want. And we can disagree that you want to follow these studies, I'll follow these other ones. No big deal. We can agree for that. But look, I could design a study that shows there's nothing bad happens when you reduce saturated fat intake or increase it. It's super easy. I just say you're eating saturated fat at 12% of total calories, increase it up to 50,000, no change. Like, that's easy to do. We know that. You could argue the same thing, that this depends on what part of the curve you're on. But the American Heart Association and all the studies show that below 5% of total calories is the most protective. You have the least amount of cardiovascular outcomes, death, mortality, strokes, what have you.
Okay, so this is a really important point that I think we need to talk about so people don't get confused. This is where I think totality of the evidence is misleading. So really, this should be a 12-hour podcast. And I think that at this point, we've talked about almost everything we want to talk about, so we'll wrap it up soon. But when you say things like the AHA says saturated fat is associated with cardiovascular mortality, I know that nested in that statement is a lot of epidemiology, right? And these are observational studies. And so we'd have to go through all of those and say, well, why are you looking at this study? And what do you think about the potential that this study is confounded by healthy user bias and unhealthy user bias? And so that's why I think that when we're looking at these, we can say, look, you can potentially find studies on both sides of the equation. To me, that suggests not that you take a step back and you do something like saying, we need to look at the totality of the evidence. It means you take a step forward and you need to look at details and say, how much could this study have been confounded by healthy user bias and unhealthy user bias? And we know that with saturated fat, that is strongly at play, because for the last 70 years, since good old Ansel Keys, the healthy people have been avoiding saturated fat and the unhealthy people are riding motorcycles, smoking, shooting guns, and eating saturated fat and butter. So there's a lot of unhealthy behaviors. When was the last time you were at a regular barbecue? And you may not go to these. I don't go to these either, but I'm asking people to think about 4th of July in your hometown. You go to like a regular barbecue. How often does somebody eat just butter or just red meat? No, you're eating butter with seed oils and bread and brownies and processed sugar and high fructose corn syrup and Coca-Cola with caramel color. And so all of these associations get very, very sticky. And so when you say things like saturated fat clearly associated with cardiovascular disease, and I can show you a huge meta-analysis of 6.5 million person years showing that saturated fat in dairy is actually potentially cardioprotective. To me, this says you don't take a step back, you take a step forward and you look at the details here. And then I can find free living populations of people who are having tons of saturated fat and don't have any problems. The Hadza, essentially no cardiovascular disease. And I went and I stayed with them, the Tokalauans, Katavans. And so I think we have to be better than this for our patients. We have to think about these things and think, okay, there's a lot of conflicting evidence here. What is the quality of each individual study? And what are we saying? What have humans done evolutionarily is not by any means the end all and be all, but I think it helps give a framework of what we're talking about, because I think it makes sense. And people would debate me on this, that what we've done evolutionarily is probably something that is reasonably good for humans. People would say, oh, no. But if I look at any free living population of humans, indigenous people, I consistently find massively lower rates of cardiovascular disease and chronic disease and diabetes. They're essentially vanishingly rare. So what are they doing differently than us? That, I think, is a clue to what we should be doing. It's not the end all and be all, but it's a clue. It's a thread that we should pull on. When we pull on that thread, what we find is they're eating meat. They're eating organs. A lot of them, like the Maasai or the Samburu, they're milking cows. They're eating dairy fat. They're eating honey. They're eating sugar. They're not eating seed oils. And who knows? I'm just saying that's the thread that I pull on and go, maybe we need to think about these things more carefully. And then when I zoom in, when I look at these studies carefully, I find inconsistencies like adipose tissue linoleic acid versus serum levels of linoleic acid, like LDL stratified for any metric of insulin resistance looks completely different than not. This is all the stuff that I think you need to zoom in and not zoom out. This is where the totality of evidence gets us in big trouble. And I think that it misleads us in terms of our thinking about these things. I mean, how can you ignore all of these interventional studies, not observational studies that I showed you? More linoleic acid, less saturated fat, more oxidized LDL, more LP little a. I mean, I just enumerated multiple studies in humans, more oxidized LDL, more cardiovascular disease, more linoleic acid in the human diet, more linoleic acid in the LDL, more likely to get oxidized. I don't know what else there is to say other than the fact that if there are studies like your ones you're showing that say linoleic acid is beneficial for cardiovascular disease, we need to zoom in and look at the details. The devil's in the details, not zoom out and say totality of evidence, because it's just, when you look at the details, what I see, and this is why I appreciate your perspective too, because I want more perspectives here. What I see is not consistent. It doesn't look like linoleic acid is cardioprotective. And I would assert that linoleic acid is potentially the worst thing that we could do for our patients by making their LDL more likely to oxidize, more LP little a, worsening male hormones, worsening outcomes in kids when they're getting more linoleic acid from breast milk. All these things, big problems for humans. And it wraps into the whole LDL discussion. So I think it's a beautiful kind of framework for the whole thing we've talked about.
Right. So just a couple of points. When they do a study, they do stratify it by alcoholics versus non-alcoholics. Let's say we're testing cardiovascular mortality. We're not going to test smokers versus non-smokers, or, does saturated fat only increase the risk in women or not? They do split them out into subgroup analyses. They will have above 75, under 75 years of age. They'll have diabetic versus non-diabetic. They'll have BMI, waist circumference. I mean, you look at ApoB or LDL, whatever you're measuring, the studies don't just throw everybody in together and say, here's the conclusion. I mean, they do stratify. They say among smokers, the people who had the highest LDL had the highest stroke rates, for example. among diabetics under age 60 with hypertension only, here's what we found. So that's not true. And I agree, we actually definitely need to zoom in on these studies and figure out more. But I think when you have a consensus statement or a guideline or a large meta-analysis, even like the ones you were pointing out, that generally means that some panel of experts, especially like guidelines or consensus statements, a panel of experts who's knows this stuff better than most of us, sat down and looked at all of the evidence and said, okay, look, from what we can tell, based on all of the evidence available from randomized, controlled trials to interventional trials, therapeutics, Mendelian, what have you, everything you mentioned, from what we can tell, this is probably good, or this is most likely the best thing. They never give you like, yes, you have to do this, or no, you don't have to do this. They have like a level 1A evidence, 2A, 1B, 3B. All these are things like what we grade evidence. Like people who've had a stroke or a heart attack, level 1A, they should be on aspirin. That means like the evidence is so strong that it'll prevent a future heart attack or stroke. Level 2B might be they should be on another blood thinner in addition to it, which means it's not as strong, but it's probably a good idea. Level 3 or C or whatever it is like, please don't ever do this. This causes harm. So I think evaluating the evidence in that way for most things, completely agree. That's literally what we try to do. So I think you're right. We absolutely need to do more for our patients, but also I think the onus is on the system. I think a lot of it is insurance companies. Most people are like, well, I pay health insurance. I can do whatever I want because they're going to fix me. This is like this new thing. A lot of people are just like, oh, I don't care if I'm hypertensive. And I'm not talking about people who have genetic hypertension, just like people got it for becoming overweight or becoming, eating high salt diets, what have you. If people are thinking, well, I already paid for insurance, they're just going to give me a pill. I'm not going to do anything. I'm not going to try to lose weight. I'm not going to eat less salt. I'm not going to eat a Mediterranean style diet. I'm not going to go running, what have you, any of these things. I feel like the system, a lot of times, the social determinants of health, the system, the government, whatever you want to call it, the way it's set up is not helping. Like I said, they won't pay for prevention. They won't say, hey, you're 20 years old, go see a cardiologist, see what he thinks, maybe he'll put you on the right track so you don't need one when you're 60. What happens is, and this, they come to me after they've had open heart surgery because of a lifelong collection of genetics, choices, what have you, added up to bad outcomes. Now, I'm not saying all of these things are preventable. Obviously, we have super lean, healthy individuals that have these problems too. Some people have just genetically insane things. No question. I'm not blaming those people. But for the vast majority of people, I'd say 70, 80% of people, a lot of what you do and choices you make can make a huge difference. And then you won't hopefully end up being the statistics that has to see a cardiologist because now you've got a big problem that you need us. So that would be kind of how I would do. If I had to give your audience 2 tips, I know you ask your people this all the time, 2 tips coming from a background of being a cardiologist and a certified trainer, I'd say definitely eat a Mediterranean style diet. And I know we don't have to agree, you eat differently. Eat a Mediterranean style diet. And number 2 would be get in some exercise. Pick something that you really enjoy and just make sure you try to do it. Don't do something you hate because you're not going to do it consistently, whether it's weightlifting or hiking or surfing or biking or swimming, just going on walks. Just do something every day or every few days that you enjoy that you can actually keep doing for the rest of your life. I highly recommend that.
I agree. I appreciate all of that. And I appreciate you coming on the podcast so much because, like I said, it's been so hard to find people who will have these discussions. And I think that we will have to have a steak at some point. I so appreciate you. And I think it's been
Look, I'm coming to Costa Rica and you will make me an awesome, amazing tomahawk.
I will. I owe you a tomahawk for sure. To your recommendations, I would add to people, and again, you don't have to agree with this, but I think that what my hope with this podcast was that we could show different sides of the issue with regard to seed oils and LDL and cardiovascular risk. And kind of like I tried my best to state at the beginning of the podcast, I want to show the differing perspectives on what the first most important target may be. I think that for people, we can probably agree that correcting insulin resistance is paramount. And I would see it as the most important thing. And so the one thing that I wanted to say as we wrap up is that from my perspective, and we don't have to go into this today, people can follow my podcast if they want this in more detail. But when we eliminate seed oils, I believe that seed oils are the primary driver of insulin resistance in humans. And so this is why I think this conversation is so important for Western medicine. Even if there's disagreements, I think that one of the things that I hate the most about the environment that we're living in now is that dissenting voices are silenced. During COVID, my Instagram was deleted because I had dissenting voices on COVID. And so I appreciate that we can have dissenting voices, differing ideas about the LDL paradigm. I've definitely tweeted things before, or I don't know, Z'd things, I don't know, whatever X is called, Twitter is called now, in the past. And I've had lipidologists say, everyone knows, in my response to my tweet or my Z'd or whatever it is, they've said everyone knows LDL causes cardiovascular disease. You're going to disagree with all of the experts in the world, Paul. To which I say, yeah, I'm going to think for myself. And I think that the consensus statements are valuable, but I want to think for myself. And I'm not going to take, even if there are 100 super smart doctors, man, put me in a room with those 100 smart doctors. And I think I'm going to start going to cardiology conferences with those 100
I think you should.
or 500 super smart doctors. And I want to talk to them. And I want to have these same discussions because I think that that's super important for us to have these dissenting discussions about all of these pieces of the equations. And I'm not just going to take a consensus statement as canon. I want to think about it. I want to think about the inconsistencies. And so I so appreciate you giving me the opportunity to kind of share what I see as the inconsistencies. We've only talked a little bit, but I strongly believe that you want the best for your patients, and I appreciate that. And so I think that's really what matters. And I strongly believe that if you're recommending a Mediterranean diet to people, that they're going to get better because they're not going to have many processed foods and they're going to start exercising. I do think the devil is in the details and that what we talked about in this podcast should not be glossed over. And I want people to listen to it and think for themselves, not take what I'm saying as canon, to not take what you're saying as canon, but to think about it for themselves. Because when people make changes to their diet, sometimes their LDL goes up. Now, predominantly their LDL is going to go up maybe 20, 30% when you're eating more red meat and butter and the things I'm recommending. But in some cases, I believe in most cases, that's probably a good thing. And that's where we disagree. But again, I want you to have the ability to kind of at the end of this podcast, summarize your thoughts on this. And I'll leave you with the last word here. But I'll just say that the way that I see it, like I said from the beginning, is that the totality of the evidence is going to ignore the details. And then when I look at the totality of the evidence for LDL, I'm not convinced that LDL is causing cardiovascular disease. We talked about veins and arteries. We talked about all of the inconsistencies in the data with LDL and cardiovascular disease. We talked about the fact that insulin resistance stratification of LDL versus cardiovascular disease is important. And we talked about the fact that you and I may define insulin resistance differently and have a different sensitivity for what insulin resistance is. I think that following up on that, it's important to understand how insulin resistant you are and to think about how you can improve that. Losing weight will improve your insulin resistance regardless of what you do. But I also believe that eliminating seed oils will improve your cardiovascular risk because we know that increased seed oils are going to increase oxidized LDL, increase Lp(a), and all the other things I talked about that are bad. So that's my perspective, that if people are eating animal-based, they're eating animals, they're eating meat, they're eating organs, things we've eaten historically for hundreds of thousands of years as Homo sapiens and millions of years as hominids, you're going to become insulin sensitive. You're going to become more metabolically healthy. You're going to get good nutrients. And we don't need to fear LDL in the setting of metabolic health. Now, make sure you're metabolically healthy, understand how to get there, and understand how seed oils may or may not be contributing to that metabolic health. And that's my recommendations for people. And I really appreciate you giving me the opportunity to talk about all that. So the floor is yours, and you can tell people your perspective on all this and summarize your thoughts on this sort of verbal repartee.
So first of all, again, thanks for having me on. We definitely agree on more than you think. And I listened to some of your other podcasts and I was like, we're not going to disagree on very much. But I agree with you that people should do a ton of research. Now, not everybody is capable of doing research. Like, I'm not going to research how to fly an airplane and then go debate a commercial airline, pilot and try to explain to them how they should be flying planes. I get that, but do your best with your own abilities. Go research these topics, talk to me, follow other people, go online, whatever Twitter's called now, or Instagram or Facebook, follow people that you feel can give you a different perspective, the similar perspective, confirm your bias, not confirm your bias, what have you. go do that. The more you know about your health, like I always tell people, don't you hate it? Like people ask me, don't you hate it when your patients Google something? No, I actually love it. I want my patients to know what is atherosclerosis. I want them to come to me, tell me, well, I heard statins have bad side effects. I want them to know these things. I want people to know as much as humanly possible so that when we come, we can have an educated discussion like this, where we can actually get nuanced and get into the nitty gritty and not just be like, here's a pill, see you later. But I love educated patients. I love educating my patients. I've been teaching on YouTube since 2008, maybe. But like I said, I think we both want the best for our patients. You worked in cardiology. I currently work in cardiology. I look inside people's arteries every day. The whole point of what everyone's trying to do in the United States, the researchers, the scientists, whether, whoever they are, whatever side of the equation they are, we want people to get better. Now, on my side, at least we believe that LDL plays a gigantic role. And I don't think you disagreed. We just disagree on maybe what sparks it or what burns it or what have you. But LDL is a huge driver of this disease. And we both agree on that. We don't eat similarly, but we both tell our patients to eat in a healthy way. In your way, it's more meat based. In my way, it's more Mediterranean based. And I think that's about it. I don't feel like I believe our goals and our intentions are both aligned. Maybe slight difference in the nuance here and there with certain things. But I will just urge people to just go get educated, learn as much as you can, try to understand. We're both available on Twitter and Instagram. Text us, message us, DM us, follow us, on all these things. Figure out how you can find us on pretty much every social thing you can. And we'll be more than happy to answer questions. I personally try to answer as many questions in my DMs as possible. I'm sure you try to do the same. In fact, that's how we met. Your DMs are probably busier than mine, but that's how we met. You messaged me and this is how we decided to do this.
Yeah.
No, but I appreciate it. I think science is always advancing. In a few years from now, none of this might matter at all. I don't know. The science definitely advances and we'll find out. We'll see.
Yeah. Thank you again. I think that it's been good. It's been good talking with you. I think that this is so productive. It's just so productive to have conversations and not to just either talk to an echo chamber, which happens too often. Even for me, it's just difficult to find people who have different perspectives. And it's just so good to have different perspectives. I wish we'd been able to do this in person because I know that if we'd done it in person, we would understand that we're both humans. And I think that social media is dangerous for people in some ways because we just get into arguments on social media and you can't see the person's face. You can't understand they're a real human. So even though this is virtual, I wish it were in person. Maybe we do another one in person. But I think that so many of these discussions could be so much more productive in person, especially when they're differing views. When you can see a human and when you can understand their perspectives in real time, it's so much better than like arguing back and forth in the comments on Instagram. I think as humans, I know for me personally, I just get like anxiety. I get stressed doing that. I don't think it's a very evolutionarily consistent thing to have, thousands of voices coming at you. And I think it brings out the best, the worst of us. At least it brings out the worst of me. And so being able to do this, I hope allows us to bring out more of the cordial side. We're both passionate about these ideas, but more of the actual human side of it and advance the discussion further. So thank you again for coming on. And I look forward to further discussions with you.